Welcome to the Temple College EMS, EMT, Behavioral Psych Emergencies portion. This is going to be Part 1, Disorders, and it will be followed up by Part 2, Assessment and Management. My name is Professor Blankenship. I will be here throughout this lecture with you. So first, let's define a behavioral psychiatric emergency. In order for us to do that, we need to know what normal behavior is. So normal behavior is defined as an adaptive behavior accepted by society. This does vary, however, based on environment, culture, and ethnicity. What exactly is a behavioral psych emergency? Anything that's outside of that norm, any abnormal behavior, a maladaptive behavior. This is also defined by society, and it's kind of broken down into 3 sections. Number 1, it deviates from society's norms or expectations. It interferes with our well-being and our ability to function in everyday life. And it also can be harmful to a person or a group or to oneself. Well, when that changes, why is this happening? There are several things that can do that. We have to rule out some underlying medical or trauma issues that may be causing that behavioral change before we can actually label it a psychiatric illness. So we can have this brief inability to cope with stress, anxiety, to even more intense situations, which may be a danger to themselves and or others. At the time of this recording, we're in the middle of a COVID-19 pandemic, and there seems to be a surge of behavioral changes in people's moods. We are told to shelter in place. People's stress and anxiety is going up. They're running out and having fear contagion and buying up all the toilet paper and paper towels that they can get their hands on that will help them. They're just hoarding, essentially, is what they're doing. But before we do jump to these conclusions, we do have to rule out a few things. So what causes behavioral change? Here's a laundry list of things that could possibly cause a change in mood change, a behavior change for us to not act right. We may just seem a little off for the day. Our brain needs 2 things to function. It needs oxygen and it needs sugar. Anything that inhibits that can cause us to act a little kooky. Or you can just look at somebody and tell that they're off, or they just may be talking funny. We may not be able to speak. We can't think straight. We may not know who we are, where we are. There's a number and variety of things that can come into play here. Following that, how do we know that somebody has a mood change that could be a true emergency? Ask them questions. Look for our clues that are around us. Be aware of our surroundings. We could have a sudden onset. That's usually some type of physical change that can happen that we can see. Memory loss, altered pupils, all these things can lead to different types of things. Maybe they're on a prescription drug that's causing these. Maybe they're on recreational medications that can cause these. Memory loss or not knowing where I'm at. Maybe I don't have any oxygen coming to my brain, which, like I said before, we need. Could be a number of things. So true psychiatric disorders, after we've ruled out all the medical trauma underlying things that could happen, start with the most common one, anxiety. When I say the word anxiety, I can almost bet that the majority of y'all, first thing that comes to your mind is testing anxiety. Every time it's time for y'all to take an exam, don't think of it as a test or an exam. Think of it as celebrating your knowledge. You are celebrating your knowledge with us, at least 74.5% of it, in order to move forward in anything, any course that you may be taking. Anxiety is normal. It can be useful and it can be necessary. It may not be, but it's our way of adapting to stress. But it can get worse and it can cause problems in order for us to function in everyday life. It is defined as a disorder that is persistent, fearful feeling that cannot be consciously related to reality. It can be disabling for some people. Some people have to get on meds. Some people have other coping mechanisms. Meditation is a big one. Going to therapy. And that states true for a lot of these disorders that we're going to go over. There are some therapeutic medication therapies. Some people do find yoga or meditation or just find their own little niche that works for them to help decrease the symptoms that arise from these disorders. In the severe form of anxiety, they can develop into panic attacks. So this is a super intense fear. It affects about 6 million Americans a year. There's really no precipitating cause for this attack, although sometimes there is. You can usually ask people what happened and they've had some type of catastrophic life event that changes. So panic attack is defined as an episode which 4 or more of the signs and symptoms of an anxiety attack pop up. Well, what are the signs and symptoms of anxiety? Well, here you go. Here's your laundry list of that. Dizzy, tingling in fingers, carpal pedal spasms. Most of that, your tingling in fingers, carpal pedal spasms, whenever you get anxious, your sympathetic nervous system kicks in. We start breathing faster. We start getting, bright-eyed and bushy-tailed. We're going to run from the bear. Well, whenever we don't breathe effectively, we can hyperventilate, and we end up having this tingling, these carpal pedal spasms that arise out of that. There's a whole bunch of other things. We can be hot or we can be cold. We can get that fear of suffocation or feeling smothered or, like we're drowning and we just can't get that deep breath in. We could feel like we're dying. We have completely lost all control, fear of detachment. You can have a few of these signs and symptoms for anxiety, but whenever we go into full-on panic attack, the rule of thumb is you have 4 more of these signs or symptoms to be considered that. Well, phobias can cause some anxiety. They can cause panic attacks depending on what your phobia is. It is fairly related to anxiety. It actually falls under the umbrella with anxiety. So it's transferred anxiety onto a situation or an object, a place, etc. It can get bad enough to trigger panic attacks. I don't know if any of y'all, have arachnophobia, your fear of snakes, or aquaphobia, afraid of the dark. Any of y'all get claustrophobic. Your patients will know what the fear is. It can be unreasonable, but they just can't overcome it. Of course, sometimes they say you got to face your fears. There are some things that you really just can't work through that prescriptive therapy that a lot of psychologists say. We have to be very honest and communicate to our patients. Let's say one of our patients is stuck in a car and we have to extricate them, and of course they're going to start freaking out because cars are getting cut on and they can't move anything. We have to talk to them. We have to tell them every step that we're taking to kind of reduce some of their fear and anxiety. Well, the opposite end of the spectrum of anxiety is depression. A lot of times they go hand in hand, believe it or not. Although it can be standalone. Depression is a mood disorder. It's characterized by the feeling of sadness, worthlessness, discouragement. It's one of the most prevalent psychiatric conditions. We're at about 7% of the U.S. population. This is not worldwide. These are just U.S. numbers. It can often follow a trigger life event, a heart attack, being told that you have cancer, some other catastrophic event, a death of a child, a death of a grandparent, a death of a parent or a loved one. It could be endless for that, something that triggers it and slumps them down into this depression. As mentioned before, we're in the middle of this COVID-19 pandemic, and a lot of people are feeling depressed because they are being told to shelter in place and stay home so we don't spread this to other people or we don't contract it from other people, to kind of help flatten the curve of the peak and surgence of this virus that is worldwide, and it's killing quite more people. One person is too many, so it's killing more than that. But more times than not, it's episodic. This depression is. It can be gradual. It can be rapid. It's kind of all over the place. There's so many studies out there and long-time studies of depression and things that can happen with that. So we're going to talk about it here for a few minutes. They may feel sad. Here's a list of signs and symptoms. They don't really have a decent outlook on life. They are very despondent. One of the acronyms, y'all know in EMS, we live a life of acronyms to help us remember things. One of the acronyms for depression, signs and symptoms, is called in sad cages. And you can relate that because a lot of times they do feel kind of trapped. Like they're in their cage by themselves and they're just lonely and nothing's going right and their life sucks and it's never ever going to get better. But so for inside cages, the IN is loss of interest. So their interest in life, in everyday function, has just depressed and gone away. For the SAD portion, SAD, the first S is for sleep disturbances. A lot of people that are depressed sleep all the time, or they don't sleep at all. They have insomnia. For the A in SAD, they can have appetite changes. Some of them eat too much, some of them eat too little. It really is so individualized. There's not one answer for everybody. We all react different to the type of things that we're going through. For D and SAD, it's a depressed mood. They're just drawden and they don't want to get up and do anything. They have no drive or reason to be productive. For CAGES, CAGES, they can have a concentration inability. They just can't think straight. They can't think hard. They can't think quick. Which those are all things that we have to do in daily life. A, for their activity level change. They could be happy-go-lucky and smiling everywhere they go. Maybe they decide to stay at home and not do anything other than get up and go to the bathroom. Maybe grab a bite to eat. If not, lay in bed. Sit outside and just be, not do anything, just be there. G in CAGES, for guilt. They feel some sense of guilt for whether they're not doing anything because of the way they feel, or who knows? I mean, it can just go on and on and on. E in CAGES, for energy or lack thereof. They just don't have that energy. The synapses in their brain are just not connecting right, and they may have some hormonal issues that take effect here too. And S for CAGES is suicidal ideation, plan, and or attempt. These people think that they are not a productive member of society. They have no will to live. They have no drive. They don't think that their life matters. So they can have these racing thoughts in there. And it's okay to ask if they've had these thoughts. Studies show that it doesn't give them that idea. We have to talk to them and we have to listen to them with intent. It's okay. We're not going to put that idea in their head. We're not going to make them go commit suicide. We're there to help. They are calling us because they need help. It's usually an outright cry for help. Bipolar disorder. Oh boy. High highs and we have low lows. It's a manic depressive. Most people go through this manic depressive state. It's an emotional disorder. They have manic episodes of highs and, then they have depressive phases of lows. The duration can last for months. It can last for days. It can last for hours. It can last for weeks. Some have been known to actually last for years too. In their mania, they're super, super elated. They think they're untouchable. They talk like blah, 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 which y'all probably think I'm talking fast. I've been told I talk fast, so who knows what that means. Just kind of keep those, they're just going 90 to nothing whenever they're in that mania phase. Depressive state, they slow down. They hide. They isolate themselves. And this is where those suicidal thoughts can come through. And we just reviewed depression, so you should be familiar with that. Paranoia. Let's quickly mention about paranoia. Also may be titled as delirium. We'll talk about excited delirium here in a little bit, or part of the delirium syndrome. Delirium can cause some paranoia. It can be caused by a number of things, and it's an elaborate, overly suspicious system of thinking. Whether it be true or not, they're just paranoid about something. More times than not, there's usually some recreational drug use behind that, or overuse of prescription meds, or underuse of prescription meds, depending on what they're, on medication for. A number of factors, again, lack of oxygen, lack of sugar to the brain can also cause these signs and symptoms that may mimic this, but we can fix those other underlying medical or trauma issues. It's also seen in schizophrenia. We'll talk about that here in a minute. So don't instigate these patients. Don't aggravate them. This can escalate very, very quickly and somebody can get harmed, and don't take anything personal. That's not what we need to deal with, it's too much burden on our mental health and our mental state if we start taking all this stuff personal. These people are having a true emergency and they need to get help. So neurocognitive disorders. A lot of literature now states that it is referred to as dementia. Neurocognitive disorders actually encompass dementia and delirium. But I think some literature is trying to separate the two now, depending on who you read or what you read. But most of the times it is organic in nature. It can include physical or chemical injury, whether they've had years of drug use or alcohol or, who knows, people that work in coal mines, that end up with all these other medical issues down the road. If and when you hear like major neurocognitive disorder, it's usually and safe to assume that they mean dementia. It has a very slow onset. It is starting sooner and sooner and sooner. I think some of the latest research is it can start as early as 40s for people, depending on how hard of a life they've lived. There are several types and forms of dementia to date. They say about 75 different variations. You may also hear organic brain syndrome. If you ever hear OBS, they're usually talking about organic brain syndrome, which is just your brain just gets tired. Your brain's a muscle, and it kind of withers away as you get older, causing some of these same type of issues and signs and symptoms. You may hear of people that have dementia going into the second childhood. They start reversing, to where they have to be fed and they have to wear a diaper and so forth, into that childlike behavior. Even their thought process goes back to childish type of behavior. Quality of life is diminishing for sure, which is very sad. Schizophrenia, I said we'd talk about that. Well, here we are. So individuals are unable or unwilling to recognize or accept reality and relate to others. You see people walking up and down the streets that have issues, talking to themselves, and whenever you do talk to them, they make absolutely zero sense. It happens, unfortunately. Usually, adolescence, early adulthood is when this starts showing up. Got a little bit of life experience behind you, and your brain starts racing all these thoughts, and they could come out of nowhere, and it means absolutely nothing. Your speech may not come out right. There's no known cure, just management and therapy. There are some medications that can help with it, and obviously therapy helps if you continue to go to it. Along with that, I told you we talked about delirium too, along with the dementia and the neurocognitive disorder. Agitated or excited delirium, it can be okay. We can have this high of high, disorientation of time and place. It involves delusions and hallucinations, and y'all know delusions are false beliefs. Hallucinations, the perception of sights and sounds and other weird phenomena that are not actually there. So the common signs and symptoms, memory impairment, disorientation, cloudiness, unconscious, and we got these others that are listed here. They may get hot, diaphoretic, because they're excited. Whenever we're excited, our sympathetic nervous system kicks in, and these are some of the things that happen whenever that takes place. So now we got to get into a true emergency issue that we can have in EMS, and we have to be very self-aware. We have to have situational awareness with these type of patients, but we can have patients who do get violent with us. They may know what they're doing, they may not. More times than not, they don't know what they're doing, and it is a true emergency, and they really have to get help. So let's talk about suicide for a minute. Suicide rates are higher than they have been in a long time, with all the stuff that we've had going on in the world, all of these mass shootings, and right now this COVID-19 pandemic, and we're all sheltering in place. Suicide is truly a permanent solution to a temporary problem. Now, on the outside, it's easy for us to say that. We say it's the chicken way out. They didn't really have to do that, and a lot of people consider it selfish for those people to do that. But you have to remind yourself that they are not of sound mind. They have been so low in their life with things that this is the only way that they think that they can escape that and not be a burden to family and loved ones. So the 10th leading cause of death in the United States, that's actually a stat from 2014. I'm curious to see where that sits in today, and we're in 2020. Second among college students. I couldn't find any literature on that, so I'm sure that's something that's published in your textbook. And women do attempt it more often than men, but men are more successful because they usually do it by a little bit more violent means. They're 4 times the rate that women do when they're successful. So I'd put this on the top of the list for violences. A threat of suicide is an indication that they have a serious crisis and that calls for immediate intervention. Ideation means that the presence of the thoughts of killing themselves is there. And then there's active ideation, which means they have a plan. They have thought this through of how it's going to happen, possibly when it's going to happen. It's such a more detailed plan. The more detailed their plan is, the higher risk of success that they have. 50% who succeed attempted previously, which means they've done this more than once. First time they may have gotten scared, and they've just continued on. It is believed that those that do kill themselves have talked about it in advance, whether that be to, family members or friends. It's been put out there. I don't think that some people may have caught it, or, that they may have noticed that it was going to come to fruition. So most of them have seen a physician within 3 months of being successful in committing suicide. All forms of suicide need to be taken seriously, no matter if they're just say they're joking around with it or not. There might be some underlying truth to it. So we really, really, really need to dig into that and get them to the help that they need. Some risk factors: men above 40 years old, usually Caucasian and over 65 years old, increases their success of actually committing suicide. Single, widowed, relationship, drug, alcohol, financial issues is a big one. If they've lost their job, which I think is on the next slide for this, if they have a history of depression, could be a number of things. Maintaining the means of suicide, that's why the mental health people, especially if they're medicated, they try not to let them have guns or ammunition or anything to that effect. Arrest, or if they're, in prison, there's a lot of suicides that get committed in prison. With suicide being the most extreme form of violence, let's chat about violence towards others. Most importantly, us as crew members and providers that are there in their emergency to help take care of them. 60 to 70%, although I don't know where they're getting those numbers from. If emergency patients become assaultive or violent in some form towards providers or others, bystanders, have to look that up. Some causes that may cause them to become violent, real perceived mismanagement. They could be under the influence of something. They could be scared. They could be panicking. There may be that underlying medical or trauma issue that can be causing this extra sense of violence for them to come at you or a loved one or, your partner or law enforcement or whoever else may be there as well. So what are some of the warning signs? What are we going to know that they're being violent or have the potential to be violent towards us? Nervous pacing. These are just assessment clues to be on high alert. You need to make sure that you got all your antennas up on your head that are going in every direction to look out for these type of things. Some people carry a clenched fist whenever they're walking around. Make sure you're looking at all these things. Have your poker face on. Don't let them know that you may be scared or in fear for your life. If things get too out of hand, back away from the scene, go sit in your truck and call law enforcement to come help you out. Also important to consider PTSD or complex trauma syndrome. Complex trauma syndrome is mostly known for victims of domestic violence. PTSD is more for our veterans. That could be triggered by something. And those patients can become violent without even knowing it in the moment. So be on high alert for those types of individuals and patients that we encounter. And that will conclude this portion of the lecture, and I will follow up with assessment and management in part 2. See you in a bit.